Hi, it's Peter Anglin again, and we're going to be discussing in a panel session the plasma cell dyscrasias around Dr. Mateo's talk, and also just a little bit about Waldenstrom's macroglobulinemia. I work at the Stronach Cancer Center in Newmarket, Ontario. I'll just ask the other two panelists to introduce themselves as well, please.
My name is Tony Ryman. I'm at the St. John Regional Hospital in New Brunswick. These are my disclosures. So Dr. Mateos has given an excellent overview of important clinical trial results presented at ASH this past December. And so I'm just going to give a little perspective on what is our currently available therapy in Canada, how that compares to what I might consider to be the best proven therapy and where there might be some gaps. And at the end, maybe just talk a bit about how some of the results presented at ASH might influence Canadian practice in the not too distant future. So on this first slide, I'm comparing available versus best proven therapy in Canada for transplant eligible patients with newly diagnosed myeloma. Most such patients in Canada will be treated with autologous stem cell transplant, although a small percentage will receive allogeneic transplant. In Canada, patients are still off study in standard treatment settings getting CyBorD induction with bortezomib, cyclophosphamide, and dexamethasone. They're receiving high-dose melphalan 200 milligrams per meter squared as conditioning prior to the transplant, and most are receiving lenalidomide maintenance. Bortezomib maintenance is sometimes selected for those with high-risk molecular features. I think the main gap in the evidence or between the best proven therapy and best available therapy in Canada is with the induction regimen, where I think there's more evidence supporting the use of a proteasome inhibitor combined with an IMiD and a steroid as compared to CyBorD. Admittedly, the level of evidence in the induction phase is a bit limited. There's conflicting evidence about the role of post-transplant consolidation therapy, and the effectiveness of this may depend a bit on the potency of the induction therapy. And so this isn't routinely done in Canada for most patients, but occasionally it's used, especially if there's a suboptimal response to the transplant. For those who are transplant ineligible, at the moment outside of clinical trials, we're still using a lot of lenalidomide and dexamethasone frontline, or bortezomib with an alkylator and a steroid. In Canada, most commonly, once again, CyBorD as compared to VMP. I think the best proven regimens are with the addition of daratumumab to those two regimens. Bortezomib, lenalidomide, and dexamethasone is also a regimen that's proven to be superior to at least the lenalidomide dexamethasone regimen that we use routinely. And so I think any of those would have more evidence behind them. In Canada, with the current access to daratumumab in the relapse setting, there's some motivation not to use both bortezomib and lenalidomide frontline in order to access daratumumab later. 4-drug regimens are interesting and include daratumumab with a PI and an IMiD and a steroid, and we're awaiting definitive results of ongoing trials there. In the relapse setting, of course, there are many options, and this landscape changes even more quickly. In Canada, for patients who had a good result from their first transplant and are fit to do so, a second transplant is often considered if there are stem cells available. The daratumumab-based regimens approved in Canada include DVD and DRD. And so those many patients who are refractory to lenalidomide after their first line treatment are being treated frequently with DVD. There are also several carfilzomib-based combinations that can be used. And then there are the pomalidomide-based combinations. In Canada, most commonly we're adding cyclophosphamide to PomDex. There are a number of proven regimens. I won't go over them all in detail. Some of them are listed here. Suffice it to say that there's a broader array of daratumumab or isatuximab containing regimens that can be used. There's elotuzumab, PomDex. There's combinations of PI with POM. For the T1114 or BCL2 high subset, venetoclax is a viable drug. There's selinexor. And many of these might actually be preferable to some of the regimens that we have available. In the near future, we can expect more indications and options for the use of CD38 monoclonal antibodies in Canada. Isatuximab and daratumumab are both being evaluated as part of frontline therapy by our regulatory agencies. Subcutaneous administration of daratumumab hopefully will come to Canada as a standard of care before too long, and this will certainly be a more convenient option for patients and a less resource-intensive one for daycare units. And we will see more carfilzomib or pomalidomide CD38 combinations available for relapsed patients who have not yet been exposed to an antibody. We may see new indications in Canada for selinexor, venetoclax, belamaf for myeloma. I guess we'll see how that goes. But these are some potentially promising agents with which we have some Canadian experience. As you heard at ASH 2020, there are a number of promising therapies in development. Perhaps the largest class of agents are those targeting the BCMA protein, expressed highly and fairly selectively on plasma cells. So in addition to belamaf, which is an antibody drug conjugate, there are other such antibody drug conjugates in development. There are, of course, many CAR T-cell constructs targeting BCMA. At this ASH meeting, I thought it was particularly exciting that we started to see some results with off-the-shelf allogeneic products, but many autologous products are in development, and so far, results are encouraging. Although we know we don't seem to be curing patients with this approach, and responses can be of limited duration, but hopefully the technology will improve with time. There are also bispecific antibodies targeting BCMA. Several of those are in development, and results were presented at ASH, and all of these showing efficacy in relapsed patients. There are two exciting new therapeutic targets expressed on the surface of myeloma cells, GPRC5D and FCRH5, for which the results of bispecific antibody therapies were presented. So it's great to see some new immunotherapy targets emerging, and hopefully we'll see further development in that area. Aside from immunotherapies, well, perhaps included among immunotherapies are the cell mods, sort of the next generation IMiDs. Some results with those you heard about from Dr. Mateos, showing some activity in patients who are refractory to standard IMiDs. So that's also exciting and potentially valuable addition to our therapeutic armamentarium. There's also a subset of patients with MAP kinase pathway alterations, BRAF mutations, et cetera, who can be treated with tyrosine kinase inhibitors targeting that pathway, and we saw some new or updated results in that area. So these are all some potential therapies that may come our way eventually. Certainly, many of these are expensive, and many of them are also early in development, and the technologies will advance. So it'll be exciting to see where this goes in the coming years. And several of these trials have been studied in Canada in the context of clinical trials. So, in summary, it continues to be an exciting time in myeloma. The advent of myeloma immunotherapy has really spurred significant growth in new therapeutic development for myeloma, and more conventional therapies also continue to develop, and hopefully these will positively impact Canadian patients in the not too distant future.
Hi there, my name is Christine Chen from the Princess Margaret Cancer Centre in Toronto, and I will be presenting today an ASH 2020 update on Waldenstrom's macroglobulinemia. These are my disclosures. So my goal in the selection of abstracts today, was to be as practical and user-friendly as possible in terms of the content. So I'll be covering frontline, second line, and beyond management approaches for Waldenstrom's, hopefully providing you with some tidbits to take back to your own practices. So starting with frontline Benamastine and rituximab, we've been using this regimen since the 2013 STILL trial showed efficacy of BR in a subset of, or rather in various indole lymphoma subsets, including a small group of patients with Waldenstrom's. Since 2013, when that study was published, showing a very good efficacy and toxicity profile compared to R-CHOP. And we were happy also to see at last year's ASH that the same STILL group presented the MAINTAIN data. This was actually a study focusing on maintenance rituximab versus observation after frontline BR. And although the maintenance made no difference, we were encouraged to see in a larger subset of Waldenström's patients, 266 in this study, that response rates were very high, and progression-free survival with BR, whether you had maintenance or not, was in the 9 to 10-year range. So BR remains our standard frontline chemoimmunotherapy regimen in Waldenström's. And the next two slides will focus on how we can optimize Benamastine-based treatment. This first abstract was a retrospective review of 230 patients with indolent lymphomas treated with Benamastine, a subset of which were Waldenström's. And they identified that lymphopenia, as not surprisingly was common in 84% of patients, developed during therapy and worsened by the end of treatment. 56% were severe with lymphocytes less than 500. And it took 9.5 months to recover it after the end of therapy. And presumably this contributed to the rate of severe infections in about a quarter of patients. These were patients requiring hospitalization. And it was interesting to see the array of opportunistic infections that they reported. There were definitely signals for increased PJP, fungal, perhaps viral. And it also was interesting to see that the approaches by investigators for prophylaxis varied, very much like what I anticipate we do in Canada. 44% didn't use any prophylaxis. On the other hand, a third of patients used both antiviral and PJP prophylaxis. And then everyone else did a smattering of other approaches. So we are not as uniform in this in prevention of infections with Benamastine. So the take-home message here is perhaps that we should consider at very least PJP prophylaxis, so pneumocystis prophylaxis, and maybe even antiviral, much like we do for prophylaxis with FCR, up to, during and up to 12 months after Benamastine treatment. The next slide looks at the optimal BR dosing used. Again, this was not just in Waldenström's patients, but it was a retrospective analysis of 250 patients with indolent lymphoma treated with BR, subset of which had Waldenström's. And they correlated the Benamastine dose with outcomes, response, and PFS, and found that frontline, the optimal regimen was full dose for the full 6 cycles, where there's a little more wiggle room with the relapse population to dose reduce or perhaps even truncate the course of Benamastine to 4 cycles, to 5 or 6 cycles perhaps. So why do I mention this? Because I know across Canada, many physicians will dose reduce BR somewhat empirically based on patients' perception of frailty or their age. The median age for Waldenström's is 70. So it is noteworthy that age did not affect the tolerated dose in frontline. So this is just a word of warning that perhaps one should try to aim for full dose BR for optimal efficacy, even in those older Waldenström's patients, as long as, and to avoid any empiric dose reductions just purely based on age. So I'm moving on to second line therapy with Abrutinib and beyond. And we all know that Abrutinib is used more and more in Waldenström's and was first approved as monotherapy based on a phase 2 trial back in 2016. And then subsequently was approved in combination with rituximab based on this INNOVATE trial, which randomized patients either to Abrutinib plus rituximab or rituximab alone. There was a cohort, RMC, of more heavily pretreated rituximab refractory disease that all received monotherapy. And so at ASH 2020, we saw an update on the, with a median follow-up now up to 50 months with the INNOVATE trial. And what we can see is that by 50 months, you can see the PFS curves on the left. The PFS for the Abrutinib arm has still not been reached. It's about 70% PFS, or free of progression, by 50 some months. So that's pretty impressive that patients can continue 4.5 years and longer after starting Abrutinib and still remain free of progression. In the arm C of patients with more heavily pre-treated disease, the PFS was much shorter, suggesting maybe we should be using Abrutinib earlier in course of treatment. And we started to see what we have observed with other reports, that the presence of CXCR4 mutation, which occurs in about 30% of patients with MYD88 mutated Waldenstrom's, portends a poor prognosis when treated with Abrutinib. So Abrutinib is highly active, but alternatives really still are needed for this significant portion of patients. Now in Canada, we don't routinely, uniformly across Canada, have access to CXCR4 mutation testing, but this kind of data suggests that it would be useful to use as a marker for stratifying for treatments. So what do we use after Abrutinib? Well, there was a lot of information at ASH on alternative BTK inhibitors, both covalent binders. These are BTK inhibitors that bind at the same cysteine 481 site as Abrutinib, and also non-covalent inhibitors that bind elsewhere. So the covalent BTK inhibitors, including acalabrutinib and zanubrutinib, are thought to have equal potency, but because they are much more specific for the BTK kinase, they may affect the kinases on heart and platelets less frequently, and potentially decreasing the usual Abrutinib toxicities of atrial fibrillation and platelet dysfunction. So we've seen data before on zanubrutinib in Waldenstrom's with the head-to-head trial, and that showed similar efficacy and some variable data on toxicity, some toxicities less, some more with zanubrutinib over Abrutinib. So perhaps what we need is more of a sequential approach, and that's what this abstract from ASH showed. The study design here was for patients who were intolerant to Abrutinib and or acalabrutinib, were then put on zanubrutinib, the much more specific BTK inhibitor. And this was a very short follow-up, but all to say that you can see the swimmer's plots here with the common toxicities, and the ones in gray show that the intolerant events occurring with Abrutinib did not recur with zanubrutinib. And time will tell whether or not patients are able to stay on zanubrutinib significantly longer, allowing them to achieve perhaps deeper response. So the biggest, though, BTK inhibitor that made a splash at ASH was LOXO-305, which, as I mentioned, is a non-covalent BTK inhibitor that doesn't bind to the same cysteine 481 site of BTK that is the main site for mutations that are responsible for the majority of relapses or resistance on Abrutinib. So LOXO-305 is equipotent against patients who have the mutated BTK versus wild type. So we were very keen to see data come out from the Bruin study. This was a study in various types of lymphoma and CLL. There was a subset, small, of 26 patients with Waldenstrom's who were subsequently tested on the phase 1 and 2. These were relatively heavily pre-treated patients, 3 prior lines. Most had had a prior BTK inhibitor already, predominantly Abrutinib, and 2/3 of them came off study or came off Abrutinib because of progression. And the data, again, are very immature, but what's encouraging, if you look at the left, is the toxicity profile with LOXO-305 is excellent. You can see virtually no grade 3-4 toxicities. Of those toxicities we worry the most about with Abrutinib, such as atrial fibrillation and bruising and bleeding. And again, data is, the The data is very immature, but we are seeing responses, even recognizing most patients were progressing on the previous BTK inhibitor. So lots to come yet on LOXO 305. So in conclusion, this was a snippet of abstracts at ASH for Waldenstrom's that I thought would be informative to our daily practice. Frontline Benamastine rituximab, highly effective. I think we're still going to stick with it, but aim for optimizing the dosing even in older patients. Consider PJP and probably viral prophylaxis extending out until there's lymphocyte recovery. And second line and beyond, Abrutinib is confirmed as being a highly effective agent with durable response. And I think just around the corner are these newer BTK inhibitors that will give us some more options for beyond Abrutinib. Thank you very much.
Thanks to Chris and Tony for your time this afternoon. For those of us that saw the talk of Dr. Mateos, it was very comprehensive. So I just want to peel some issues away from that and frame it in the Canadian environment. I'll go to Chris first. Transplant in Canada in 2020, Chris. It remains the standard. Can you just talk to us a little bit about upfront versus delayed transplant in 2020, where that may be going?
Yeah, so that was a theme that emerged from ASH 2020 with the long-term follow-up from the IFM trial. Now we're out almost 8 years in follow-up. This is the trial that looked at immediate transplant versus delayed. And we also saw some data from the EMN02 trial, a European trial, again, looking at the same question. And both have, as I said, long follow-up and continue to show that there's a benefit to early transplant, not just because you can achieve deep responses that leads to longer progression-free survival as compared to delaying, but also because not everyone who gets delayed ends up getting transplanted for one reason or another. On the EMN02 trial, the patients delayed, of those, only about a third ended up getting their transplant. And one can anticipate that that may be because they run into comorbidities, complications, they lose their performance status that enables them to undergo treatment. So it may not really be a fair comparison of early versus late transplant, may end up being early versus no transplant. So currently at our center, we continue to offer transplant frontline. That said, you asked about 2020, and we are in the middle of a COVID pandemic. And it isn't always safe to proceed when you think the risk of community COVID is high. So we have certainly delayed patients for their transplant, but the goal is to try to minimize the delay, maybe only a few months, and not waiting until they progress and transplant at relapse. So that's our perspective from my center.
Tony, let me ask you, we hope at some point that, and we're going to get into relapse refractory myeloma, but we're all waiting for MAIA to be approved so we can give patients a 60% PFS at 4 years. How do you think when we get DARA combinations up front, how that's going to impact decisions to take patients to transplant?
Well, it's a great question. I mean, we have data that says daratumumab improves outcomes in just about every setting in which it's been tested. And we have a little less data on exactly how much it improves outcomes in patients who go on and have a transplant. And, you know, I think if we really want to know the answer to that, we may have to do those trials, and it might take 10 years or more to get the answer. But, you know, to me, it seems like, you know, we're going to need good evidence not to sort of take Christine's perspective about incorporating frontline transplant. You know, if patients are sufficiently impressed and doctors are sufficiently impressed with the long-term outcomes in the transplant ineligible population, we may see more and more patients choosing to defer transplant, and maybe more and more doctors starting to become a bit more comfortable with it. But I think right now we're all still just hoping our transplant ineligible patients can get, you know, the best proven first-line treatment in the near future, and so we're still waiting for that.
One more transplant question to you, Tony. MRD directed transplantation, how far away from that? where we're looking at MRD status. If they're MRD negative, do we not transplant them? Is that, do you see that in the next 5 years?
My short answer is I don't personally see that, just because we've got data on MRD, particularly in the IFM trial of early versus delayed transplant that Chris was talking about. And it still looks like there's a benefit to early transplant, even if you achieve an MRD negative response. So, the mantra used to be, it's not about how you get there, it's just whether or not you achieve MRD negative status. But I'm not sure that's completely true.
Yeah. Thanks, Tony. Let's shift gears, transplant ineligible. Chris, right now we have RD available. RVD actually is available in different jurisdictions in Canada, depending on getting the compassionate bortezomib. And then bortezomib-based regimens, CyBorD, VMP. Chris, can you talk to us about how you're approaching transplant ineligible patients, particularly RD, RVD, how you're teasing that out in broad terms?
Yeah, so our standard for many years from the first trial was to use RD. We didn't talk about VMP because it's a kind of an older regimen that is no longer very popular, but RD being all oral became our standard. And then the data from the SWOG trials comparing RVD to RD in not necessarily a strict transplant ineligible population, but patients who weren't planned for frontline transplant, was really encouraging, with the PFS of RVD of like 43 months, much better than the 26, 27 months we typically expect with RD. So we've largely, and you're right, the ability to access the bortezomib component for RVD varies across the country. But my approach is to try to use the best regimen we have access to. So we do try to access RVD for all our patients, but recognizing that the original RVD in the SWOG trial was not very user-friendly, that the bortezomib was IV twice weekly. Patients developed, there was a third of them developing severe neuropathy. So we've since, at least my approach is to water it down a bit to be closer to the RVD light approach, where the doses of bortezomib are decreased sub-Q weekly, and it's just more palatable and less toxic regimen that can be given to older patients. So when you modify that way, it's pretty tolerable. The bortezomib is not endless, so you stop, again, it varies depending on which regimen you're using, but let's say for the SWOG trial, you stop at 8 cycles. So patients aren't left with a parenteral drug endlessly, so they just continue with the lenalidomide long term. So that's actually pretty tolerable. So my approach is to aim for that. We all have handfuls of patients who absolutely can't tolerate or are not interested in parenteral, where RD would be my default.
We actually stole your regimen, and we find it's easier and well tolerated as well, Chris. Thank you. Tony, I hate to give you Len refractory patients, but I'm going to. Big challenge. Just a few things that came out from ASH. I think we looked, the DVD data doesn't look good in Len refractory patients, at least on one of the 8 months on one of the trials. Again, we want to have to be careful about cross-trial comparisons, but can you talk to us a little bit about the Len refractory patient, what you saw in ASH? The Candor data looked quite interesting in terms of the Len refractory group, but your thoughts on Len refractory patients, a challenge for all of us.
Yeah, I mean, these days, most patients are going to become Len refractory after their first line of therapy, either because they're getting maintenance post-transplant or they're having Len-based frontline therapy. And, I'll just comment that you don't want the patient to also be bortezomib refractory at that point, if you can help it, so that you can access DVD, because in my jurisdiction, you can only get daratumumab combined with RD or Velcade-Dex after relapse. So DVD is kind of something we have to go to locally, in that setting. But I think we all agree that outcomes could be better. And so to that end, there are various CD38 combination therapies in the relapse setting to consider. You can use both daratumumab or isatuximab, at least according to the evidence, in combination with carfilzomib dex and improve outcomes compared to KD, which we know from prior studies seems to be better than bortezomib dex. So following the logic, that may improve outcomes compared to DVD. Beyond that, if you have sort of exhausted your proteasome inhibitor approach, then pomalidomide combinations tend to be what's available to us next. And of course, there's a long list of drugs that are being combined with PomDex to try to improve outcomes. And so it just depends on what you've got left and what's available.
Well, as we kind of move down first line, second line, we can get more nebulous here, that it's only by design. Chris, I want to talk to you about your selinexor expertise. It's a drug that we can get in Canada compassionately right now. Chris, can you talk a little bit about how you use POM, or how you think about pomalidomide in nth line therapy, which may include selinexor and other things? Can you frame that a little bit for us? It's a loaded question.
Unfortunately in Canada, we are a bit restricted with when we introduce pomalidomide regimens because of the mandate to have had failed a proteasome inhibitor and an IMiD, as well as have had 2 prior lines. So when you look at POM combos in that setting, it almost doesn't make any difference what third agent you add to the PomDex. It all ends up with a PFS somewhere around a year. So just unsatisfactory from all pictures. So you end up choosing not by efficacy, but by tolerance, by preference, by whether it's all oral or, there's the inconvenience of parenteral, because there isn't one clear efficacy winner. So there's where maybe selinexor PomDex is encouraging from a perspective of convenience. It's all oral. Selinexor has a bit of a bad rap based on its data from using much higher doses in the combination with dex. But as we move into triplets, we're able to see that the efficacy can be synergistic with the other agents, and we can then drop the dose. And it's much more tolerable in that way. So with selinexor with PomDex uses a weekly dose of 60 milligrams, where as a doublet, we used to go up to 100 BI, twice a week. So I think it can be managed in terms of tolerability, and it does present advantages from a convenience perspective. What I'd like to see with PomDex combos is moving it further earlier, because we are seeing data such as the combination of, say, Dara PomDex. Again, if you use it traditionally after you failed IMiD and PIs, the PFS from the Apollo trial is still only about a year. But if you move it further earlier, as was presented by the MM014 trial, then you can, we saw at ASH that the PFS can be extended up to 30 months. So I think if we are less restricted by where we place POM combinations, we can really make use of it. And I do think we're going to have to move it earlier as we start to get DARA or monoclonal antibody containing frontline regimens in place, that now we're going to have exhausted our monoclonal antibody. We will be lenalidomide refractory. We may or may not have already had exposure to a PI. So we're going to have to shift earlier.
Absolutely. Tony, I know I'm moving quickly here, guys. I just want to get into cellular therapy. Tony, the ASH data presented looked pretty impressive for penta-refractory patients. Patients have everything, including a CD38. Response rates 90%, CR rates 2/3 of patients, survivals approaching 3 years in this heavily pretreated group of patients. How do you see CAR-T fitting in the Canadian environment in the next year or two? Are patients going to have real access to that?
Well, I think in the short term, it's going to be, through clinical trials and special programs, perhaps. But I think what separates cell therapy in myeloma from cell therapy in B-cell lymphoma is that we're not yet convinced that we're really curing people, and we're not yet completely happy with the remission durations that we're getting. And so I think people would either have to find a way to bring the cost down so that the cost effectiveness was felt to be acceptable by the Canadian system, or the technology is going to have to improve so that the efficacy shifts that cost effectiveness forward. And certainly very promising. I mean, there were no less than 14 or 15 BCMA targeted therapies at ASH, about half of which were CAR T therapies presented, some short-term, some long-term. And we've got new immunotherapy targets coming, and we've got new technologies to improve the toxicity of cell therapy and hopefully the efficacy. So I think it's just very promising. The response rates are remarkable, and I think people have leads on how to improve this technology. And I think the challenge will be how to deliver it, efficiently and cost effectively in our environment.
Tony, last question about myeloma to you. In the next year, what do you see as the biggest change you may make in your myeloma practice?
Well, I'm hoping it's going to be frontline daratumumab for transplant ineligible patients. That seems to be getting close to the finish line.
Okay. Chris, in the next year for you in myeloma, what do you see as the biggest change making it into the clinic and affecting patients in the next year?
Yeah, I'd agree with Tony that that's going to be a game changer, because now you're getting DARA frontline. And that, I mean, we talk about that as the game changer, but then it affects all your downstream treatments, right? So you're going to become LEN refractory earlier in the course of disease. So everything, our usual algorithms will no longer apply. We're looking forward, I don't know about the next year, but accessing these better triplets with KD as a base, right? Like such as DARA or isatuximab plus KD. And even, we didn't talk about this, but even our age-old cyclophosphamide added to KD looks really encouraging from not only the data from Mateos, but also from our own MCRN data with using weekly carfilzomib, much more palatable than twice weekly. So we can kind of access that. Cyclo is dirt cheap. It's a nice Canadian addition to regimens. That's something that might start trickling into the clinic in the next year.
Okay. One question quickly, Waldenstrom's, Chris, thank you for that succinct and brief summary. How important is the rituximab with the Abrutinib and when we treat patients with relapsed, partly from access funding challenges and all those things? So how important is the rituximab, or do we know?
Yeah, we don't have any head-to-head Abrutinib versus monotherapy versus Abrutinib plus rituximab, right? The Innovate trial compared IR to rituximab monotherapy. So all we have are sort of trials where we can look at the outcomes and cross-trial comparisons. Doesn't look like the addition of rituximab is really that necessary, as we are seeing from much more rigorous data in the CLL population. It does lead to faster responses, and perhaps there's some inkling it may be helpful in patients with CXCR4 mutations if you are using Abrutinib. Those who are a little more refractory to treatment, perhaps, but we don't have the data, and right now access to that combination is limited. So on the whole, I'm still using mostly the Abrutinib monotherapy for patients. The odd patient who needs a very more rapid response, I might add the rituximab in, but again, usually needing to take advantage of their drug insurance to access it.
Okay, thank you. Chris Chen, Tony Ryman, thanks so much. Great discussion. Appreciate your insights. Everyone enjoy the rest of the meeting. Thank you, everyone.
Thanks very much.
Thank you.
Bye.